So the Mass Association for Community Development Corporations is a membership organization that represents 64 community development corporations across Massachusetts that all do work in low and moderate income communities. We seek to build and sustain a high performing and adaptive community development sector that's supported by private and public investment and public policies. And so my role as the program director for health equity is to help to drive one of our strategic priorities, which is to drive the convergence of health equity and community development. And what that looks like is facilitating our member engagement in work that impacts health outcomes in communities, and also facilitating relationships in the health space. And in particular, as hospitals are increasingly recognizing their role in impacting the social determinants of health in their communities and also as anchor institutions, MACDC helps to identify overlapping priorities between community development corporations and among hospitals in Massachusetts. And before I turn it over to Robin and Megan, I just want to emphasize that I know that there is a ton of wisdom and a ton of experience in this room. And I hope that the toolkit that you're going to hear about today is going to be just one more tool that you can use in your existing toolbox. And I also hope that this session today will be an opportunity. We're going to have some time for breakout groups and discussion to kind of think together and strategize together how we can collectively move the needle on impacting social determinants of health in our communities. And you'll notice that most people in this room come with a hospital affiliation, but we've also invited a few other folks who are also really key thought partners in this area. So we hope that it will be a really enriching conversation. So I'm going to turn it over to Robin and Megan. Robin Hack is the executive director and the co-founder of the Center for Community Investment, and she works on hospital investment. And Megan Sandell works with Dr. Thea James at Boston Medical Center and spearheads Boston Medical Center's housing initiatives. So I will turn it over to Robin and to Megan. Thank you for joining us.
Great, thank you, Alana.
Ooh. Robin, I'm so sorry. I just muted you when I meant to mute myself.
Oh, okay, no problem. Here we are. Well, thank you, Alana. It's a pleasure to be here with you, and it's always a pleasure to be Megan's sidekick because she has been such a proponent of this kind of upstream investment and has really, I think, both personally and institutionally championed what's possible. And in any field at the nascent stage of development, which is where this work is, having champions who are tireless creators of bright spots is actually a super important piece of how innovation happens. So happy to be here. I'm going to talk a little bit about what we've learned over the last 3 years as the Center for Community Investment has run a program that we call Accelerating Investments for Healthy Communities. And in that program, we have been working with and learning from 6 health systems, including the Boston Medical Center, that already before we touched them, were investing upstream in the social determinants of health. And so we have had the opportunity over the last 3 years to work really closely with cross-disciplinary teams inside those institutions, as well as with the community partners in each of their geographies that are helping them put their money upstream and affect the health of the community. So that's the toolkit that you're going to see today and that you're invited to explore more on our website. That's where the information comes from. So the first question that you might be asking yourself is, why in an age of COVID, when there are so many challenges and distractions for health systems in particular and for society as a whole, why are we talking about investing upstream? And by upstream, we mean outside the 4 walls of the hospital, and in fact, outside of healthcare itself. So we're talking about housing or grocery stores or other assets in the community. Well, the reason that we're doing that is that more than ever, we know that place matters and that wellness depends on the kinds of opportunities that people have where they live, work, and play. And so, for example, having access to a safe and affordable home is a real determinant of wellness. And if we think about how do we deploy capital so that we can not only get that capital back, but produce at least a minimal economic return, then that's why people are in this game. And I've got to say that one of the most heartening things for me about the last 15 months is that not a single one of the institutions that we've been working with in this initiative pulled back as a result of the COVID pandemic, even when the staff that was assigned to work on it was furloughed. So the hospitals assigned additional people, usually more senior people, and the work kept right on chugging, which I gotta say made my heart sing. Next, please. Next slide. There we go. So why not just make grants? You know, if we think about community benefit and the investments with a quotation mark that people are already making upstream, why not just focus there? And I'm not advocating that we stop focusing there, but the scale of transformation that we need in our communities is just simply too big to be achieved through grants alone. If we do, in fact, get a giant infrastructure and stimulus investment out of the federal government, that's going to help a great deal. But it's really a combination of impact investment, as well as government subsidy and philanthropic grants that are going to be needed to transform the communities that have been the subjects of systematic discrimination for decades. Next. So, as I said, grants are super important, and we really want people to be thinking about that. But the investment side of the house has a different flavor of money. And that flavor of money can be used to achieve things that grants alone either can't do, like creating a credit history for an organization that has never borrowed before, or that grants are often too small to do. So if we use grants to kind of unlock capital from investors who might be a bit more hesitant, then we can get 5 times as many dollars flowing to the things we care about as if we just simply funded them ourselves with grants. So when we think about investment and grants together, we have more strategies that are at our disposal. Next, please. So we often find that people talk about investing upstream in kind of poetic terms, like, you know, we invest in the future of our children, and I'm very much in favor of investing in the future of our children, but our children usually don't pay us back. And what we're talking about here as investments are actually things where there is a source of repayment. So grants can get used for spending and operations and things that are one and done. And investments, in the way that we're using it here, are longer life assets being financed with money that turns around and comes back. So both important, but different. Next. And so this is my slide of the 3 knots. So when we talk about upstream investment for the purposes of the program that we've been running and for this toolkit, we're actually not talking about healthcare. And again, we recognize the importance of healthcare. We think it's really terrific to have school-based clinics and mammogram vans and all that stuff, but that's not what we mean by upstream. When we talk about upstream, we're really talking about addressing the root causes of health inequity. Similarly, we're not just talking about patients or plan members or covered people. We're talking about the community as a whole. And then finally, we're not just talking about services like, you know, matching people up with available apartments if they are experiencing homelessness. There is a shortage of those apartments. We're talking about creating more. So again, just like grants and investments, not mutually exclusive, both important. What we're talking about here is really the community health investments that address the root causes of health inequities in our communities. Next. So 4 years ago, we did some research, which kind of it launched us on this adventure, in which we identified who were the health institutions that were already doing the kind of innovation that we were looking to promote. And I'm a former venture capitalist, and people like to say that the future is already here now, it's just not evenly distributed. And so when we're thinking about spreading innovation, it's often really helpful to understand what are the pioneers doing, why are they doing it, what are they learning, and how can we promote those lessons in a wider audience. So when we started this research 4 years ago, we kind of had the idea that the pioneers would be motivated by really two things, which on this slide are number 1 and number 7. We thought that it would be all about mission. And so Catholic institutions, for example, have been leaders in upstream investment. And so we asked a lot of people from Catholic institutions, why do you do this? And they said, we stand with the poor. And for safety net hospitals, very much a similar motivation. For children's hospitals, we heard very much the same thing, is that we know that in order to have the healthiest community, these kinds of investments are essential. We also kind of expected that we would hear something about financial returns, and those actually came up an awful lot less than we thought they would. People sometimes were motivated by the idea that kids with asthma would have fewer visits to the emergency room, or that people experiencing homelessness would be able to be cared for in a better way if there were more investments in permanent supportive housing. But what we found, to our great surprise, and I got to say to our great delight, is that there were a much broader set of motivations that were actually behind the actions that the pioneers had taken. And I think they got phrased in different ways in different institutions and by different people in the institutions. But really what we found very commonly was that people perceived that their institutional self-interest was advanced by making these kinds of investments. And what did that mean? What that meant is that the hospital maybe was contemplating a campus expansion. Maybe they had a merger. Maybe they needed some kind of zoning variance. There was something that the institution wanted, and being a good citizen, making the mayor happy, making the neighborhood happy, making the community happy, was a really important way of getting that thing. So it was very hard to measure, and it was sometimes a little embarrassing to say. But when you really scratched beneath the surface of what were people doing and why were they doing it, that turned out to be quite a big motivation. Another motivation that was really interesting was, we call it skate where the puck is going, and that would be kind of under the strategy bucket. We found a lot of institutions that said, hey, we think the transition from paying for volume to paying for value in the healthcare environment is inevitable. We can't predict the speed at which it's going to happen, but we know it's going to happen. And having the opportunity to experiment with strategies that we know are going to produce better health for the community is something that we want to be doing, developing the relationships, making the mistakes, learning the lessons before the spotlight is on us. And so for strategic reasons, this is really important. And others, mentioned competitiveness. They said, in order to attract staff or patients or get contracts with corporations or governments, we're getting asked, what are you doing for the community? And this is part of what we can answer. And particularly if we're making investments where our capital can recycle, we can invest in a housing project and then be paid back and then do it again. And that really contributes to a positive reputation in the community. So these motivations, which we heard from the board level, from CEOs, from chief clinical officers, from financial folks, often in different words in the same institution, really did create a kind of powerful set of motivators that not only got people to the table, but kept them there. Next. So the other thing that we learned is that the more people inside the health system that got to the table, the more kinds of assets were getting harnessed by the hospital's work. And again, this was pretty unexpected for us. So we thought that we were going to be talking about community benefit dollars. We thought we might be talking about foundation endowments or about other kinds of investment resources that the hospital might control. But what we found was that when we asked the hospitals to intentionally put together a multidisciplinary team, the people that they brought also brought other assets with them that we might not have thought about initially. So for example, when we started the AIHC program, we often got sent to the community benefits department. And we said, you know, in order to participate in this program, you have to bring us somebody from your finance side. And the answer was almost always, actually, we don't know anybody from our finance side. So we would send people off on a treasure hunt, you know, go bring us the head of the finance person. And what they found in many cases was that the finance people were motivated to do the kind of impact investing that we're talking about here. And nobody had ever asked them before. So exploring what it would look like to deploy that kind of investment, not in huge dollars, not with 95% of the money that's available, but with, you know, small experimental deployments was something the financial folks were happy to do. And similarly, we said, you know, find us somebody who knows about real estate and facilities. And in 3 of the 6 hospitals that we worked with, it turned out that the health system owned land in targeted neighborhoods that they were thinking about disposing of. And the idea that that land could be leased to the community, could be used for affordable housing, was actually not something that had come up as a subject for discussion. Expertise in relationships, when you brought on the government relations folks, when you brought on the CEO or board members who were sitting on the boards of philanthropies or were involved in foundation work, you know, there were relationships that could lead to additional financing. In one case in California, a hospital realized that the stakeholder that they could bring to the table was the state of California. The hospital ended up making a $1.3 million investment in a housing project, and the state made a $20 million investment. So those kinds of relationships really translate into dollars and cents, but you have to be thinking about them broadly. Next. So I'm going to turn it over at this point to Megan to sort of share a little bit about Boston Medical Center journey. And what's been interesting for us is that as a safety net hospital, the BMC folks really show what's possible for an institution that is not the wealthiest institution on the block to be doing around this kind of work. And frankly, it has been quite an inspiration. So Megan.
Well, thank you so much, Robin. I wanted, first of all, thank you for all of your kudos. I'm really appreciative. I feel like we at BMC have learned a lot from the Center for Community Investment. So I really do encourage people to check out the full toolkit. And we obviously at BMC, our door is really open because we, you'll see after this slide, kind of, it takes a team approach. So we're looking forward to working on everyone's team around how to do this. I think for people who are familiar, we're trying to take a pretty intentional approach at Boston Medical Center. So where we are trying to think about this work is that to improve the health and well-being of people who live in Boston's historically disinvested neighborhoods. For us, that's kind of Roxbury, Dorchester, and now Mattapan kind of focus. We're really trying to think about how housing and economic mobility pathways act as opportunity systems. And so what started for us as a housing journey now is feeling like both housing and economic mobility. And I think for those who know my kind of compatriot in this work, Dr. Thea James, she's been talking about economic mobility for maybe a decade around how we need to be thinking about this upstream work in that way. We started, if you look at kind of the map that's the left-hand side, is we started with an initial $6.5 million investment, which was part of our determination of need obligation, where we did investing very intentionally in creating investment funds out of those DON obligations. So we did an investment in the Healthy Neighborhood Equity Fund, which is an equity fund that was founded by Conservation Law Foundation and MHIC, Mass Housing Investment Corporation, where they were like defined as investing in neighborhoods where they could show not just a financial return, but also a health metric return. We also did an investment in a healthy retail fund to fund a grocery store in one of the buildings that was being built in Nubian Square through Nuestra Comunidad, where we're financing a grocery store. So stay tuned on that. We're going to be leaning in pretty hard to building out that grocery store, not just as a grocery store, but potentially as a Black-owned business, and what are the financing strategies that are needed in order to make that happen. And then also we most recently made a commitment to 3 affordable housing projects, providing gap financing to those projects to get them across the finish line, kind of to accelerate the investing in healthier communities. And we're trying to use that as a model of how do you create more supportive housing in projects that target medically complex families and individuals. I do need to give a shout out that part of our obligation also went to the Innovative Stable Housing Initiative, which is a collaborative started with Children's Hospital and Brigham and Women's, where we've been pooling our dollars, particularly around policy work, because that's part of the enabling environment that needs to happen in order to see this as a scalable approach. And then lastly, we're really excited about kicking off the Boston Opportunity System, or BOSS Collaborative, with some startup funding from JP Morgan Chase's Advancing Cities, where we're really trying to think about patient equity models to create Black wealth creation in these neighborhoods, and think more intentionally around how does both a job and a small business and a housing strategy fit together in terms of bringing new capital to these neighborhoods. So I'm really excited. I think we have just a few more slides. I'll turn it back over to Robin, and then we want to get to your questions. Thank you.
Great. Thank you. So next slide, please. So what do you do if you're looking to get started? We think that there are really 5.
That's okay.
I just want to get back. I just got to run to do a visit.
Okay.
Okay.
Oh,
Okay, there we are. 5 basic principles that you may want to consider as you're putting together an upstream plan. The first is figure out who else in your community is working on the kinds of upstream investments that are of interest. And here's where I would say, for community hospitals and smaller institutions, for institutions that are just putting a toe in the water, you know, the dollar amounts that you may have at your disposal may seem small to you, but they are going to be welcome new capital for people who are not used to having hospitals in the game. So identifying the people that you can collaborate with, be they foundations, community development, financial institutions, banks, other employers, you know, find your peers. The second thing is to really figure out, where are you going to get the bang for your buck? And how can your dollars either unlock money from other people? How can they have the greatest impact? Where are the but-for opportunities that you can really make possible? The third is that this is not our area to dictate. This is our area to listen. And so being community driven, as the organizers say, nothing about us without us. Who are the authentic voices of the community that need to be listened to, whether they come from neighborhood organizations or CDCs or churches? Understanding what it is that the residents of the communities that you're part of are most interested in seeing happen is really critical. We also suggest that people think system and strategy rather than transaction and narrow opportunity. So it's important to get going, but it's also important to see any step that you take as part of a larger whole and try to fit the puzzle pieces together. And then last but not least, don't expect that you're going to solve longstanding problems in one transaction or in one action. This is work that requires a good deal of patience, as I tell myself almost every day. And so being patient, which some of us are better at than I am, is really an important piece of the work. Next. So we have a lot more about each of these steps in the toolkit, and I would refer you on the next slide to the link to the toolkit. But basically what you want to do is you want to lay the groundwork inside your institution by finding the people who are in the different departments that you might be able to work with. You want to choose your focus. And my little tip to you is, if you don't know what your focus should be, housing is a great place to start, because in almost any community, hot market, cold market, doesn't really matter. Housing is almost always a basic need. It's well correlated with health outcomes. And as an asset class for investment, it's the best developed piece of the community investment landscape. So hard to go wrong with a housing focus, but there are other things too: food, small business, you name it. Finding partners, as I said, this is a team sport. So you may want to talk to your community foundation, to the CDCs in your community, to CDFIs. And it's not just one partner, to the extent that you can become part of a collaboration or an ongoing platform, that's really helpful. Then you want to turn your attention to what we call the pipeline, the investable opportunities that either are or could be going on in your community that would make a difference. You create some threshold criteria for what it would take for you to get excited and move on something. And then you think systemically about what contribution can you make, not only by writing a check, but also by influencing policy, by changing practices, by thinking about what you in the hospital can do to advocate for the kinds of changes that need to be made, and you put the package together. But the most important thing is to get started. So next, we have just a couple of sources that you might want to look at. This toolkit is on our website, Investing in Community Health, and this is our address, centerforcommunityinvestment.org. We have a paper specifically on the hospital's motivations. And if you have questions that don't get addressed today, I would love to hear from you, and my email is on here. So we do have a few minutes to take questions, and then we're going to break out into groups.
There was one question that came in the chat, which was a great question from Christina, asking, as a small community hospital without large funds to invest, she's interested in hearing about how to invest in upstream improvements.
Well, some of the question, goes to what can you find out that's already happening in your community? And so if, for example, there are housing investments or grocery stores or bodega renovations or other kinds of capital improvements that are going on, you may not be able to write a $5 million check, but your institution may be able to, make a $250,000 investment that you'll get back over a 10-year period. So some of it is just about calibrating the size of the check to the size of the opportunity and the institution. Some of it is about figuring out how do you mobilize other people in the community so that you become part of a larger whole. And so that can be very valuable. And sometimes the resources that are required, especially for the community organizing piece, really are just small grants. And so as part of community benefit, you might just be thinking about, is there a way to deploy community benefit dollars so that they really strengthen the community investment system? And so thinking about the most powerful use of the dollars that you're already putting out can sometimes be enough. I don't know, Megan, if you have anything to add there.
Yeah, I was wondering, Cass, I don't know if you could go back to slide 9. I feel like slide 9 is just a really nice summary of different things that, like, I think, sorry, I think you overshot, but I think that one thing is land, for instance, is something that we at BMC kind of felt like we didn't have. And then when we started looking at it, we were like, oh yeah, actually there is some land that we could maybe partner on. I do think expertise and relationship building is another area that I think we've been leaning into pretty hard in terms of being able to build relationships, not just with local community development corporations, which there's 60 of them across Massachusetts. I suspect most people know them, but I think building really good relationships with your local CDCs. We've been working with 3 of them closely. Madison Park, Nuestra Comunidad, and Codman Square, and have found it really enlightening to learn about what their pain points are and what those different things can be in terms of opportunities. I mean, I'll be honest, the reason we invested in a grocery store is because Nuestra was like, well, would you invest in a grocery store? And we were like, yeah, we would actually. It's not something that Thea and I thought of. It was something that they brought to us. So this kind of pipeline of deal concept that Robin is talking to, I think it's really important. There are things that you're not aware of that other people are aware of. And then I do think that as we think about relationships, being able to potentially leverage dollars that a typical donor wouldn't bring to the table. So for instance, like we're trying to partner with the New Commonwealth Fund around Black and Brown wealth creation. I think us being an endorser as a hospital is bringing new people to the table that may not be thinking about the community development space as intentionally. So I feel like, I mean, Lowell General guys have been working really hard on the chronic homeless approaches with the city. I think you could be bringing new resources in terms of expertise and relationships to potentially catalyzing some of the dollars that are going to flow through the federal government to Robin's point of the American Rescue Plan that could be housing related and not just for emergencies, but actually creating more long-term affordable housing.
And I'm going to just mention 3 other strategies that cost no money, which are always popular with institutions that are strapped. The first is to use the balance sheet to provide a guarantee that unlocks money from other financial investors. So if we share the deck with you folks later, you'll see an example further on from Nationwide Children's Hospital in Columbus, Ohio. And what they did was they guaranteed a $1.5 million piece of a larger housing fund that was being put together by a community development financial institution. The likelihood that they will ever have to act on that guarantee, in my humble opinion, is very small. They wrote no check. They just used the strength of their balance sheet to say, if these developments get into trouble, we will step up and make that commitment. But that was an unfunded guarantee. And because of their commitment, they were able to unlock a $15 million fund for affordable housing. So that's one way. The second way is to think about, where do you put facilities that are outside your campus? And so we've seen hospitals doing master leases in mixed use buildings that are really important to the community. So you can put a clinic or physician's offices or back office services into a building that is really important to the community, and by leveraging space arrangements that you would be making anyway, you can get something completed, and that's a really great way to contribute to development. And then third, you can take money that is currently in a large commercial bank and put it into a local bank where that money can circulate locally. There's also a product called CDARS, C-D-A-R-S, which is a regular CD. It has federal deposit insurance, and you can put money in there for as much cash as the hospital is managing. And that money, again, circulates in the community. So these are 3 strategies that don't involve writing big checks, but they can make a difference.
Great. Thank you so much, Robin and Megan. So I want to make sure that we have plenty of time for breakout groups. I'm wondering if we may want to do, I know Paul had a question in the chat, so let's maybe take that question quickly and then we'll go into breakout groups. And just so folks know, I'm not sure if I said at the beginning, the way we're arranging the breakout groups is that we'll have the hospitals in a breakout group, and then we'll have folks who are here who are public servants or who are community representatives or other in the other breakout group. And if you think you got assigned somehow to the wrong breakout group, just go back to the main room and we'll help you out. Or if you have any other issues or questions. But before we do that, let's quickly go to Paul's question. Paul, do you want to say your question, or I can read it from the chat? You need to unmute.
You're on mute.
Happy to ask it. Hospitals that have a lot of investable monies, have to get a diversification of their portfolio anyways. And I assume some of them include real estate investments. So my question is, when they invest in affordable housing, is that viewed as, let's say 5% of their portfolio goes into real estate, this is part of it, or because it has a different kind of a rate of return, it's more like a charitable investment? How are these things viewed from an investor's perspective?
So there are all kinds of ways that health systems that we're familiar with have made these investments. And as you point out, depending on the return expectation of the individual investment, they may be classified differently. In some cases, institutions like Common Spirit Health or Kaiser have made an allocation for impact investment in which they are specifically not seeking to maximize financial return. They're looking for a blend of social impact and financial return. So in the case of Dignity, that's about $300 million. In the case of Kaiser, it's about $250 million. And those assets are specifically impact investment. The Healthcare Anchor Network has asked institutions to make a commitment to invest a certain portion of their investments in health benefiting upstream kinds of investments. And so the institutions that have made that pledge have a specific dollar target that they are separately accounting for. But every hospital has its own way of doing it. And I think in some cases, the boards are really excited to track that investment. And in other cases, the CEOs are like doing it with as little noise as possible. And so it's a very individual thing. Okay, so I guess we're going to break out at this point. And then, as I said, if we don't have time to address your particular question, we're happy to hear from you, and we're happy to address the questions individually. One other thing I will say while we're breaking out is on September 22nd and 23rd, we're going to be co-sponsoring with Nationwide Children's and with the Robert Wood Johnson Foundation a virtual national conference on these issues. And so if you're interested to get more information and to participate in that conference, then register on our website for our newsletter. And when the save the date for that goes out in the next few weeks, we will make sure to include you. We'd love to see you there.
Great, so I'm going to open up the breakout room. So we'll see everybody back here in about 15 minutes. Said in the group I was in, I hope that this was either the beginning or maybe the middle of a good conversation. I know that we had a really great conversation in the hospital group, and I hope that the other group did as well. I was hoping to give you a more interesting name, by the way, the non-hospital group, but Zoom only let me put in a certain number of characters, so I apologize for that. But I hope that that people will continue the conversation. Both, I know that the folks at the Center for Community Investment are excited to continue the conversation, but I'm also at MACDC happy either to help facilitate relationships with CDCs in your region, or also, just to be a thought partner in thinking through some of this stuff. So please be in touch. Don't hesitate to reach out. Before we close, is there any thing either from our presenters or any burning thoughts or questions from the group that you want to share in the last couple minutes that we have together?
No, just thank you for the opportunity. And Ilana, if you would like to circulate the presentation to folks who are here, we're happy to have you do that.
Great, thanks, Robin. Happy to. Joe, did you want to say something? I saw you just unmuted.
I was just going to say thank you. Thank you for joining us. Thank you, Robin, for the presentation and all this good work that you guys are doing and your teammates there. And let's keep the conversation going.
All right. Thank you all.
Thanks, everybody. Take care.